My name is Yu, a PhD student in nutrition. I'm really honored to introduce our speaker, Dr. Wendy Demark-Wahnefried. She is an adjunct professor at the University of Texas A&M Anderson Center, a Webb chair in nutrition science, and an associate director in Comprehensive Cancer Center at the University of Alabama, Birmingham. Also, she is working as a senior scientist in a variety of centers in UAB with outstanding researches. She received a PhD in nutrition science from Syracuse University in New York in 1988. After graduation, she started a professional career in the State University College of New York and moved to the medical center at this university as an academic faculty in 1991. She has published over 119 articles in excellent journals since 1990, and they include American Journal of Clinical Nutrition, Cancer, Nature Reviews of Clinical Oncology, and etc. She also published numerous invited papers, letter to the editors, and the book reviews, and she participated in the 13 book chapters as a writer. She is an active member in American Association of Cancer Research, American Dietary Association, American Society for Clinical Nutrition, American Society of Clinical Oncology, and other academic societies. She has presented her researches on seminars and conferences more than 10 times every year to share her effort for cancer survivors. Now she is working as an editor or reviewer on a number of scientific journals as well. Her main research topic is the effect of dietary intake, physical activity on cancer survivors. She is participating in the development of the program for cancer survivors from prostate, breast, and colorectal cancer, surveying the impact of the program, which involves physical activity and education, and the setting up the guidelines for the cancer survivors. Today, she is going to talk on the topic diet and exercise recommendation for cancer survivors. What is the state of the science, and are there effective interventions? Please join me in welcoming Dr. Wendy Demark-Wahnefried.
Thank you for that very kind introduction. I appreciate it. I'm going to go and see if I can find my cell phone, and just so that I can keep on time, though I'm wondering where it is. Let me just get it out here.
That clock's pretty good.
Oh, is that clock good?
Sometimes it's not, but
Student of the obvious. Problem with me. I just want to say in this talk, thank you very much for inviting me. I appreciate it. I had the honor of serving with Rob on the AICR review panel that occurred this summer, and I was asked when I was approached to give this talk about the recommendations for cancer survivors and what is the evidence behind that, and talk a little bit about the interventions that we have going. Now, I am I kind of worked my way up the ranks being a clinical nutritionist for a number of years. I know that, how many people here are in the coordinated master's degree internship program? Okay, so there are a couple of people. So anyway, that's where I started, and life is funny. Sometimes you think that you're going to be, in the clinical practice for many years, and then opportunities open their doors, and they kind of push you or pull you into different directions. And research is an area that I got pulled into, and I'm really happy, though I wish the funding line would be better, and I'm sure that a lot of you are in that situation. So anyway, so to talk about the diet and exercise recommendations for cancer survivors, what's the state of the science, and are there effective interventions? So let me proceed without further ado. So objectives, I hope to leave you with some just an understanding of the trends and the prevalence, mortality, survivorship of cancer, to talk about some common issues that cancer survivors face, to identify diet and physical activity guidelines, and then the evidence, again, to support them, the rationale, the scientific basis. List some of the gaps in knowledge. Maybe some of you are going to go on and be be a researcher in this area. So where do we need some more contributions? And then as far as practitioners go, where can you find reliable sources of information? And then also some insights as far as where are the good studies in the field. So to just talk about cancer, basically cancer affects 1 out of 3 Americans, and here are the sources or the different, just let me orient myself here. Here are the numbers for new cancer cases. Just some things to point out. Prostate's the most prevalent cancer in men. Breast is the most prevalent cancer in women. Then you go down to the organs where both men and women have. So both genders have lungs and both genders have colons. And so we have the 3 top cancers are featured here. Just something to point out, sometimes people aren't familiar with this, but particularly people that aren't in the field, but men are more prone to cancer than women, and it could be because of their genetic background, or the fact that they only have 1 copy of certain genes, and they also practice riskier behaviors. So we really don't know what's the contribution there. Men also tend to be bigger than women overall. I'm probably an exception to that rule, but they have longer colons and more prone to colon cancer, probably just based on square footage more than anything else. But then also poorer diets. So here are the numbers as far as cancer deaths go. And again, men die of cancer more frequently, but the numbers are turned a little bit. People don't survive lung and bronchus cancer. So that really leads the throng as far as cancer deaths. Same thing in women, and then followed by your hormonally driven cancers and colorectal cancer. But then you have some of the bad players. Pancreatic cancer and ovarian cancer in women, again, that really aren't very high in prevalence, but they very much represent the deaths due to cancer. Now, because there is this differential between basically 1,600,000 cases of cancer being diagnosed and roughly 600 cancer cases dying every year, you have an excess of about 1 million cases of people that are diagnosed with cancer that are going to live. And most people that are diagnosed today, 60% of people that are diagnosed with cancer today will live at least 5 years beyond their cancer diagnosis. So the number of cancer survivors is increasing dramatically. And by 2020, there's going to be 20 million cancer survivors in the U.S. Right now, cancer survivors make up around 4% of the U.S. population. And that number will climb as baby boomers, the number of baby boomers increases because cancer is a disease of aging. We are also having better screening and better treatment. So again, all those reasons make for higher numbers of cancer survivors. But when we think about cancer, we have to also think about the whole person. We can't just say, oh, well, this is a cancer case and talk about carcinogenesis. We also have to think about what happens to that person that has cancer. Well, a fair number of them go on and have progressive disease, so that the cancer does eventually kill them. A fair number have second primaries. In fact, the most prevalent cancer nowadays, it wasn't featured on the slide here, but second primary, so second cancers after that initial cancer diagnosis. So once a person's diagnosed with cancer one time, they're much more prone to be diagnosed with cancer a second time. Cardiovascular disease, number of our therapies really affect the heart. and particularly agents like doxorubicin, which is used for cancer chemotherapy. And that really does, so that damages the heart. Radiation to the left-hand side of the body damages the heart. So cardiovascular disease is a big thing. Diabetes, osteoporosis, sarcopenia, and then functional decline. And these two are, those of you that are in the exercise world, these are really big problems. So much so that once a person's diagnosed with cancer, oftentimes they are rendered, they go through this, they basically fall off the cliff as far as functional ability. And many of them need to be, can't live independently. So that's a huge cost for the U.S. Economy. And if you look at functional limitations, cancer survivors have significantly more functional limitations than your average people in the general population. So this graph kind of shows that people in the general population that are featured here in the red bar, people that are cancer survivors featured in the yellow bar, and there's significantly more psychiatric problems in cancer survivors, significantly more activity of daily living problems, functional problems. Here's where you really see it. In that, 60%, almost 60% of cancer survivors have at least one functional limitation, and then problems with work. So this is a population that's really in need and crying for intervention. So what are the solutions to that? Well, diet and exercise are potential solutions. And this chart shows possible benefit for 1 check, probable benefit for 2 checks if you look at the literature, and then convincing benefit denoted by 3 checks. And it really grieves me that I am a nutritionist here, because look at the checks. Diet has this many checks and exercise has this many checks. So there's a lot more benefit for exercise than there is for diet. But, really, fortunately, both of them have a number of checks here as far as counteracting some of those downstream effects that cancer survivors have. So depression, fatigue, adverse body composition, functional decline. But here is where cancer survivors have a lot of comorbidity. Again, they're more prone to second cancers, they're more prone to cardiovascular disease. And we do know for years that diet and exercise are important for both of those. So there's convincing benefit there. Here is where the science is growing, hopefully, with the NIH or the NCI will still be around and still be funding people in this area. But this is where a lot of the studies are targeting now to see if we intervene with diet and exercise, can we stop recurrence? And there are a couple of really big trials going on right now. One is the Challenge trial that's headed by Carrie Kernier out of the University of Alabama. University of Alberta, how did I get those two confused? That is looking at exercise, and does exercise actually prevent recurrence and progression of colorectal cancer in patients that were recently diagnosed. And given the size of the crowd, if anybody has a question while I'm going through, please just belt it out and we'll take it as it comes. So here are the recommendations for cancer survivors as far as what the ACS recommends over here, 2012. They've been making recommendations for cancer survivors since 2001 was their first set of recommendations. And basically they have been making recommendations. They've been revisiting every 5 years. And I've had the pleasure of serving on this panel. In 2009, we met, and in 2009, we got into a big fight about supplements, and people couldn't come to agreement, and we all went home without recommendations. And then we met again in 2011 and revisited it and came back again. And then the other organization that makes recommendations for cancer survivors are the World Cancer Research Fund, American Institute for Cancer Research. You'll see that there are similarities between these sets of recommendations here. So weight, be as lean as possible without becoming underweight. And then for the American Cancer Society, it's a little less stringent. It is achieve and maintain a healthy weight during your lifetime. So what is the science behind that? Just so that gives you an understanding of where these recommendations are. Yes, please come up, sit in front. Don't be shy. Don't be shy. Come on.
We'll edit it out of the camera.
Yeah. There you go. There's a seat for you. So energy balance has been a big issue in cancer survivors. And really, if you look over time about the science of cancer, people that have been diagnosed with cancer, anorexia and cachexia is a big thing. And when we think about what a cancer patient looks like, oftentimes our mindset automatically, even though I deal, most of my studies are on obesity in cancer survivors, if somebody says, oh, conjure up an idea of what a cancer survivor what a cancer patient looks like, I immediately kind of have this picture of a wasted person in bed. And indeed, there still are wasted cancer patients in bed. Those of you that are in the clinical nutrition program, you're on an oncology floor, this is what you see. You see a lot of people that have GI cancers, lung cancers, and they're wasted. Some childhood cancer are wasted too. So this is a definite area of research. Once people become cachexic, we really don't have ways of stopping it. There are some interventions in fish oil that are being looked at now, but really, it's kind of a field where much more research has to be done. However, that being said, overweight and obesity are becoming more and more the norm for cancer patients. One, they're a risk factor for many cancers. Second, they are just in the background of living in the 21st century here. So I'm going to really kind of talk more about this. Here's a map worldwide of obesity. If we featured obesity in the nation, I live in an area where obesity is probably featured really dramatically. We have a huge number of people in Alabama that are obese. But here are the red spots are where a high proportion of people are overweight or obese. Worldwide, there are 35% of adults are overweight, 11% are obese, and that number has doubled. 65% of the world's population, so by far the majority of the world's population, live in countries where obesity is going to kill more people than hunger and underweight. And the medical costs for obese people are much higher than they are for people who are normal weight. So those things are driving more research in this area. If we look at cancer and we look at the statistics as far as different cancers and whether obesity is a risk factor, there are 6 cancers here for which obesity is recognized as a risk factor. Breast that occurs post-menopause. So if breast cancer that occurs in young women, obesity is not a risk factor. In fact, being lean and being tall is a risk factor for breast cancer that occurs in young women. But being fat is a risk factor for breast cancer that occurs over the age of 50. Colorectal cancer, endometrial, and these bars, the purple bar represents overweight and the blue bar represents obese. So you'll see that there's a dose effect here between overweight and obese for all these cancers. Endometrial, this is definitely a weight-related cancer where obesity plays a big role. Kidney cancer, esophageal cancer, and the newcomer is pancreatic cancer. Question?
So what is it measuring?
It is measuring, this is actually the increased risk. So,
This is above.
but above normal.
Okay.
Percent or fold change?
It's a percent, yeah. And and then the other thing too is the evidence is growing. Really, I think we're at the cusp of ovarian cancer and there's also gallbladder cancer also joining these 6 other cancers. So there are probably 8 cancers that are obesity related. And then, so that's one metric of how obesity plays into cancer. Here's another one. obesity is related to cancer-related mortality. So not only getting cancer, but now dying of cancer. And here there are many more cancers that now join the fold here. In fact, you have 15 cancers that for which obesity is a risk factor for cancer-related mortality. And then looking at weight gain. And we look at, here are the cancers of the two top cancers. So we're talking about breast cancer and prostate cancer. This is a recent study here by Chan, 2014, just last year. Meta-analysis, 82 studies, so a large number of studies blended here, combined population of over 200,000 people. And what they found is that the women who were, for every 5 kilogram per meter squared increase in BMI, you got almost a 30% greater risk of breast cancer mortality and 8-fold increase in total mortality. Prostate cancer, not as much, the data are not, there's not as many studies, a smaller cohort, but you're basically seeing the same sort of thing, an increase in cancer biochemical recurrence with PSA detecting recurrence there, and then prostate cancer mortality being really the hard endpoint. So, so weight gain after diagnosis is not great either. So, so news to the, when I was a clinical dietitian in the 1980s, I remember my first patient, and she came to me, her name was Daisy, and the doctor said, you need to put her on a weight restricted diet. I said, she's a cancer patient. How could I do that? And because there was a stigma, oh, you can't, we have to feed cancer patients. We have to give them all these shakes and all this other kind of stuff. And so it was like, it was very different. But nowadays, yeah, you don't feed a cancer patient. We're finding that out pretty much. And here are the speculated mechanisms. We don't really know for sure all the mechanisms that drive it. However, theorize that inflammation, adipokines and growth factors play in here. Sex steroids, if you're overweight and you're a woman, you'll have more estrogen. Not only will you have more estrogen, but less, because you have less binding protein as you get obese, more of that estrogen is free. Or if you're a man, more of that testosterone is free and freer to act on the target tissue. Insulin, you just have increased substrate levels. You'll have more free fatty acids, you'll have more glucose roaming around to feed that tumor. And then you have other conditions that will play in here. So diabetes and other comorbidities that could be factors in what drives how obesity drives cancer. Diabetes, again, being probably the most easy to intuit. And then different substances like metformin and statins being able to modulate that role in those pathways. So we have been doing a lot of weight loss interventions in cancer survivors, and we're not the first ones. The first weight loss trial that was ever done in cancer survivors was this first one by Duard, 102 postmenopausal breast cancer patients. And you'll see here that the publication date is 1993. This occurred in Europe and showed weight loss. Since that time, there have been 14 weight loss trials in breast cancer survivors of different length. And none of them have shown any kind of adverse events. 57% have resulted in 5% loss or more of body weight. And we've seen improvements in lipids, and we've seen improvements in inflammatory markers, blood pressure, quality of life, a whole variety of markers, but nobody has been able to follow these women long enough to see an effect on recurrence. So, and nobody has had a study that's big enough to look at recurrence. So currently in the field, there are some studies that are aimed at seeing, do we make an impact either on, well, let me rephrase this. All of these studies have started off with the hope that that we would have a sample size that's big enough that we could actually prove an effect on recurrence. However, some of these studies have wrapped up, and you'll see here, the first one was a LISA trial. LISA trial was looking at mailed materials and a weight loss, distance medicine-based weight loss program in women with breast cancer on letrozole, and was ultimately was initially planned as an amply powered study. You'll notice here 336. This is not amply powered. It will take a sample size of around 2,400 to 2,500 women in order to show an impact on cancer-related recurrence. So this fell really short. Why did it fall short? Because it was funded by a drug company, and the drug company pulled the money. So that study won't go any farther than that. We had a study, energy study. It was question.
I'm just wondering how you came up with that number for how many people you would need for significance. For the power analysis, or how?
Yeah, you do a power analysis, and what you figure is that the recurrence rate in women with breast cancer. If you take different stages of women with disease, you look at the recurrence rate in those women, and you postulate, well, how much could you reduce that, and that will give you your number. Now, what's working against you is that the recurrence rate in breast cancer. Now, women that are woman that's diagnosed with breast cancer today will 90. It depends on the stage. If you are talking about stage 1 women, 98% of women will have a 5-year survival. So that's huge. Very few women recur. If you dip down and you say, okay, we'll use stage 1 and stage 2 women. Now you're talking 90%. So it's not like women with breast cancer. Very many of them will recur. So that's what your numbers are really driven on.
So how different is this from having women that are not cancer survivors? So is this response that they see different from?
It still is, it still is greater than if you were in a healthy population, and if you were going to do a weight loss trial in just healthy women that were postmenopausal, you would have a higher cancer event rate than in the general population. But still, we're talking about small numbers. So, if you really wanted to, if you wanted to do women that had stage 3 disease, you would need far fewer numbers. And oftentimes, then people like me sit down and say, okay, well, what are the chances we can get women with stage 3 cancer to participate in our trial? And so there's a different set of factors that vote against it.
I meant all those results that they have observed. Is that different from in healthy women? Yes or no? Because these studies don't show that. So
No, they just show the weight loss.
that's what I meant. So there's no difference between a cancer survivor and somebody that is not a cancer survivor when you do this weight loss.
The only thing that's different is the retention rate. So if you do a weight loss trial in a healthy population, you get about 50% of your people dropping out. Here, working in cancer survivors, they're a little bit more motivated to stay in. And so your dropout rate is less. So that's what you have. And there are some studies that show that once women go through chemotherapy, they are less likely to lose weight. And that could be because we have really, that chemotherapeutic agent, particularly some of them are really nasty. Doxorubicin is one that affects the cardiac muscle. But they also affect just the, the skeletal muscle too. And whether we're seeing decreased metabolic needs in those women makes it harder for them to lose weight. Question?
So I was curious about differentiating, breast cancer in African American women is really quite different.
Triple negative.
It's triple negative, it's much more likely to be premenopausal.
Mm-hmm.
They are much more likely to have recurrence within 5 years. There is nowhere near a 98% 5-year survival.
So that's a specific target population where a lot of studies are saying, okay, let's leave, taking the whole bus along, with us. Let's just really target those people and see if we have an effect there. And there is some evidence that suggests that diet and exercise is more effective in triple negative, and some that says no. So we still don't have the answers to that question.
What type, is there a specific type of exercise or anything that shows one type is more beneficial than the other? So
Well, resistance training or strength training really stops some of that sarcopenia, or and make an impact there. So there have been studies in that area. In fact, we did one of the first studies that showed that women that get chemotherapy lose muscle mass, but if you actually employ a resistance training exercise to those women, you can actually keep them where they are. So that's important.
Sorry, you said this, are they dealing with overweight or everybody?
They're all overweight. There is no shortage of overweight women with breast cancer. I can assure you. In fact, that's the typical phenotype for these studies. So yeah. So with our energy trial, this was geared as a Vanguard study. And again, our study got 692. Again, too small to see an effect on recurrence rate. We were really hoping that once we had our results, we could show it to the NIH and they'd say, okay, we're going to fund a larger study for you. Well, the NIH basically said, oh, sorry, we don't have any money for that. So this is a trial that's not going to be able to give us an endpoint. But there are some others in the field. Diana 5 is still in the field. Again, a little bit puny here. It will be interesting to see. And then the Success C, a little bit puny again. I don't know if we're going to get our answer to that question. So, but there's a lot of interest. We had an IOM workshop on cancer survival and cancer recurrence and obesity. The American Society of Clinical Oncology just came out with their position statement on obesity and cancer, and this was just released in November. So the president of the American Society of Clinical Oncology came out and said, obesity is one of the things that we're going to start intervening on. And so really mobilizing physicians to take an active stance in that area. So going down the list of recommendations, regular physical activity. What do we recommend? And I'm just going to concentrate now on the American, the ACS recommendations here, just because they're easier to feature. But here, 150 minutes a week, include strength training, again, because of that sarcopenic obesity. Here are the different effect sizes along with the confidence intervals that you see with the various factors, quality of life, emotional well-being, fatigue, pain, sexuality, sleep disturbance. And what we find is exercise has a lot of positive effects across the board for a lot of different outcomes here. So this was a Cochrane review. And then this just came out recently, and this was pre to post diagnosis change in physical activity and how that played into total and cancer mortality. And what you see here is that they have, oops, wait a second here, sorry. I apologize. But what you see is a favorable response as far as exercise goes in preventing total mortality and cancer mortality. That an increase in physical activity is associated with increased mortality and survival and cancer-specific survival. So but those are all based on observational studies. So we don't know what comes first. Is it the fact that the people that feel better and that are going to live longer are more active? Or is it the fact that that physical activity actually prevents the cancer? You can never tease out what's happening there with observational studies, right? So we don't know. If we look at dietary patterns and what people should eat, this always used to be the first thing that we used to tell people, oh, eat lots of fruits and vegetables, they're good for you. Well, the evidence is such that, yes, we see that there's evidence that eating a plant-based diet is beneficial. However, it just so happens, though, that the data are much stronger for body weight and for exercise than they are for eating more fruits and vegetables. But, and some of the evidence for eating a high fruit and vegetable diet is is kind of intertwined with body weight. People that tend to eat a low energy density diet also tend to be leaner. So what's really at play there? But the ACS guidelines say choose foods and beverages in amounts that maintain and achieve a healthy body weight. So this is the one rationale here. Limit processed and red meat. At least 2.5 cups of fruits and vegetables a day. Choose whole grains instead of refined grain products. And if you drink alcohol, drink less than 1 drink a day if you're a woman, or 1 or less if you're a woman, and 2 or less if you're a male. And so here are some data that look at red meat consumption. We know for colorectal cancer, in particular, red meat consumption is a risk factor. And then here are the hazards ratios and the confidence intervals for every increased serving per day. So you basically increase your, and I know I'm talking, here I am in cattle country and people eat barbecue all the time, but it's not good for you. I can't slice it any other way. 10% increase for every serving extra for just plain old red meat. And if you eat processed meat like bologna and hot dogs, well, then it's even worse. So, and then this is just one study, but most of the others show that kind of effect. If we look at cancer survivors, there have been a number of studies in cancer survivors that have looked at diet quality. Here's cancer-related mortality here, other cause mortality here. And what you see as far as breast cancer goes, now granted this study by Vreeling is a little bit different than these 2 other studies by Kremke and Kwan, in that it doesn't seem like it matters about the breast cancer mortality whether you eat a prudent diet or whether you eat a Western diet. A Western diet meaning lots of beef and lots of sugar and all that, and unrefined grains. And a prudent diet meaning eating lots of fruits and vegetables and whole grain products. So you're really not going to be protected as far as breast cancer mortality, but you are for all-cause mortality. So, here's your cancer-related mortality over here. Your point estimates of your confidence intervals are overlapping, but all-cause mortality, you see that you have some protection. So for that particular diet. So considering that when you're dead, it's a very hard endpoint. This is important. Cancer survivors can die not only of their cancer, but they can die of heart disease. In fact, more of them die of heart disease than they will of their cancer. So this is an important message to eat a prudent diet. For colorectal cancer, a little bit different story. There's only one study that's been done by Meyerhart. He took stage 3 cancer survivors of colorectal cancer, and what he found is that the Western diet was bad as far as not only all-cause mortality, but then also colorectal cancer mortality, in that it predisposed people toward dying anywhere from 2 to 3 times at higher rates. Whereas the prudent diet didn't really seem to do too much.
Is the difference, my reading of that is that the Vreeling study did show an impact, okay?
for the Western diet and cancer-related mortality.
Right.
Mhm. Yeah.
And so could the difference between the Breedling, the Quan, and the Crohnke be that the top two did not exclusively include postmenopausal women?
Could have been, yeah, it could have been. Although what you would expect is that here you see this, if you were going to postulate that you'd have an effect, you would expect these populations to have had, well, I guess you did. No, maybe not.
Obesity, as you pointed out, is a risk factor, I might add, in white women postmenopausally,
Mm-hmm.
not in black women.
Yeah,
Okay, so I just think that it may be a little bit more complicated than that in the premenopausal. Because they're going to have different kinds of drivers.
yeah.
Just a thought.
It is a thought. Now, the breathing study was done in Australia. These were done in the United States. So, yeah, so that's just something to bear in mind.
Yeah.
So we may be talking about different
Apples and oranges.
population. We may be talking about different methods of meat preparation. I don't know. Well, there's a lot of factors going on here. Now, the studies that actually, the clinical trials in this area have, there's been two that have been very interesting, that are fully powered. And these were done in a different era. In fact, you'll see here the publication date here is 2007. So these occurred during the late 1990s to the early 2000s. The Well study was a study of over 3,000 women. And what they intervened in these breast cancer patients with is a diet that was very high in fruits and vegetables and low in fat. So by very high, 5 servings of vegetables a day, plus 16 ounces of vegetable juice, plus 3 servings of fruit. So this is a lot of produce going into these people. 30 grams of fiber, 15 to 20% fat diet. So very, very high fruit and vegetable diet. Look at the difference between the intervention group and the control group. Nothing. It couldn't be more equal if you tried. However, the problem with this Well study diet is that this study was really done primarily in California. That's where they got most of their patients. Look at the baseline serving of fruits and vegetables. Why would you intervene? They're already there. Chances are that we see there's a threshold effect with fruits and vegetables, and beyond once you get beyond a certain amount, it's probably not going to be protective. I'm not really sure why this study was designed this way. I would never have done this study myself. But anyway, that's what they did, and so they didn't see an effect. As opposed to this is the WIN study. Now the WIN study, again, we're talking about postmenopausal women with breast cancer. They're looking at events, and over 2,000 women. They put 1/3 of them on a low-fat diet, very low-fat, 15% or less of calories from fat, so very, very low-fat diet, and versus a regular diet. So the regular diet's the blue bar, the low-fat diet's the yellow bar. And what you see here is you see a significant decrease in women that were on the low-fat arm, and particularly they did not, because they thought that the most of their effect would be in ER positive people. As it turns out, most of the effect was in ER negative people, which was really kind of mind-blowing to the investigators here. But this showed that a low-fat diet's effective in preventing recurrence. And because ER negative, this would really have ramifications for triple negative disease. Now, the caveat with this study is that the women that were on the low-fat diet lost 6 pounds during the course of the trial. By reducing their fat, they reduced their amount of calories, and they lost weight. And many people say, well, was it really the fat, or was it the fact that they lost weight? And we don't know because they're perfectly compounded. Alcohol. So alcohol, serving on this guidelines panel is hard because there's no amount of alcohol that's safe for cancer. It's not like heart disease where you see some protection with some alcohol consumption. So really, we kind of take the American Heart Association guidelines, knowing that most cancer survivors are going to die of cardiovascular disease, then will die of their cancer. And we say, okay, we'll just adopt those across the board because there's really no safe amount of alcohol for cancer survivors. However, if a person does have an alcohol-related cancer, like head and neck, where the odds ratio is just boosted out the wazoo with alcohol, we definitely say that if you have kidney cancer, if you have head and neck cancer, you should not be drinking. However, with breast cancer, again, more breast cancer survivors are going to die of heart disease. So we kind of say, well, you got to look at your family tree and really determine, do most people in your family die of breast cancer, or do most people in your family die of cardiovascular disease? And that is going to have to point you. In this area of precision medicine, maybe we'll have some more definitive answers, but right now we don't. And here's just a chart of alcohol use and second primaries. And what you see here is that despite the fact that I just told you that alcohol, we basically give some license to drink to women with breast cancer, you will find that if women will not die of breast cancer more often if they drink, but they will get breast cancer more. So they may have more breast cancer events if they just keep on drinking, but they won't die of the cancer per se. So it's a kind of a nuisance factor, if you will. Whereas head and neck cancer survivors, they definitely will die of their cancer if they don't stop drinking. And then finally, obtain nutrients through foods first. Consider supplements only if you are deficient by a registered dietitian. So this is an area, there's a lot of crackpots out there that recommend supplements, and they are not warranted. So what evidence do we have for that? Well, we have different, there's different, I realize I'm talking here in the Hall of Animal Science, and there is a lot of animal studies and a lot of cell culture studies that have looked at dietary supplements and have shown favorable things. However, when we start to put those into humans, they don't act necessarily kindly. And the ATBC and the CARE trial showed us that when we give people beta carotene and when we give them vitamin E, they actually develop more cancers, not less. Select trial is another trial that showed us that when we give people vitamin E, they get more cancer, not less. And then there's meta-analyses that show us antioxidants and beta carotene are not warranted. And we, for years we said, well, but maybe multivitamin supplements. So, maybe one a day. Well, then we got the NIH-AARP study that showed that even if you take multivitamins, you're not safe. So you really need to get your vitamins through food. There have been a couple of trials in cancer survivors that have looked at different things. Beta carotene was one of those things. Beta carotene was tested in a study by Susan Main and in head and neck cancer survivors, and she actually ended up cutting this study off after she found out what the results of the CARE trial were, and really cut them off a little bit too soon because you'll see here that her point estimates and her confidence intervals are, they're just far too wide to really understand what was going on. Though if you were going to make a call, you'd say, oh, well, beta carotene may look like it might be protective for head and neck, but risky for lung cancer survivors. But here is a fully powered trial by Brady testing alpha tocopherol, which is vitamin E, and then beta carotene. And here you clearly want it to be, here is the percent survival, and it's much greater in the placebo arm than it is in the vitamin arm. So cause for concern here with supplements. So what's the line on supplements? Rely on food as a source of nutrients. Again, you have to, make sure that the diet is deficient before taking any nutrients. And if you were going to take any kind of supplements, you would want to take some whole food supplements or herbal supplements, something that's closer to a whole food than to a refined product. There's also some synergy, and I realize my time is growing short. I'm just going to really kind of encapsulate this slide and basically say that the more recommendations you follow, the better off you are. That's it. Where do cancer survivors fall? Well, we see that there's a lot of work to be done. Cancer survivors have lots of room for improvement as far as physical activity, eating a better diet, not smoking, and that goes across the cancer spectrum. So breast cancer down to skin to melanomas. And if we look at the percent overweight and obese, basically you're talking about a majority of cancer survivors are overweight or obese. So there's a lot of room to intervene there. So a little bit more about this energy trial. Again, I kind of mentioned it. This was a trial that was done, a Vanguard study done in 4 sites, of which Alabama was part of it, but University of Colorado was, University of California, Sherrill Rock was the lead site. And then a group of us joined in WashU, University of Colorado, and the University of Alabama. Our initial hope was that we would recruit 200 people per site. And here's our inclusion and exclusion criteria. We wanted to make sure that we had adult survivors. We took pre and postmenopausal. We took people whose BMIs were 25 or greater. And we basically excluded anybody for whom an unsupervised physical activity diet or regimen would be contraindicated, or had dietary restrictions that were hard to work in. Here's our flow diagram that basically shows you need a lot of people, because we basically screened over 7,000 people to be in this study. And we kind of trickle down here, and this is the amount that you randomize, and they're assigned to one of 2 arms. Our characteristics, when you open a trial, you hope to get an audience that is ethnically and racially diverse. But here you see that 84% of our population is white, and most of them tended to be stage 2 disease, which was good. Our intensive intervention, how we intervene with these people, is that, and I'm going to race through here. We put them on group classes, and they have a lot of telephone counseling calls. And that was pitted against a usual care intervention where we gave them two sessions with a nutritionist, kind of mirroring what was standard of care. And then here are our measurement points. So we measured a lot of anthropometrics, quality of life, and kind of talking about our analysis here. Now, our results are submitted to the Journal of Clinical Oncology. I can tell you verbally that we had a nice significant difference between our intervention group and our control group, but I cannot really feature the data here and really give you specifics beyond that, except to say, hopefully look at the next, or look at a Journal of Clinical Oncology that's coming soon. We also have been doing a lot of pre-surgical trials in people who are scheduled for surgery, and we have been intervening, putting half of the people on a energy restricted diet and running them around like crazy to make them lose weight. So we do this in men with prostate cancer and in women that have DCIS. And then when their tissue comes out, when the surgeon takes out takes off a breast, a lumpectomy, or the surgeon takes out their prostate, then we look at that under a microscope and see how fast the cells are dividing, as well as a host of other molecular markers to see what's going on when we make these changes in the diet and changes in physical activity. Our study on prostate cancer is about to end pretty soon, and our study with the DCIS is just occurring now. And I'm going to end with one of our most interesting interventions on gardening. And to say that gardening has been touted as a way to keep people healthy since Cicero, ancient Rome. And when we did a pilot study, we found that people, when we put them on a gardening intervention, they improved their fruit and vegetable servings. 50% of them improved their fruit and vegetable servings by at least one serving a day. 67% improved their physical activity by 30 minutes a week. And then we had some increases in physical functioning, really, that were quite impressive, as measured by a 6-minute walk, grip strength, their what do I want to say, 8-foot get up and go, all these different types of physical activity things. So how we did this intervention is we gave people supplies. We either put a raised bed in their yard or we gave them 4 earth boxes. And we paired them with a master gardener from the cooperative extension who took them through a year of gardening, a summer garden, a fall garden, and a spring garden. Here's some of our master gardeners out in the gardens. Texas has master gardeners. In Alabama, we have 44 master gardener associations and over 2,000 master gardeners in our state. I don't even know what the stats are for Texas. But master gardeners are people who have gone through training to learn about gardening and that have to volunteer 50 hours a year in order to maintain that certification. So here, oops, I just want to, oh, don't tell me. I don't think my slide is working. Oh, here it is. Okay, so I'm just going to leave you with the videotape and then I'm going to stop.
As a garden now, cancer survivors was one of the first participants in the UAB study called Harvest for Health.
I like the idea of growing plus taking better care of myself and the part of that. Having fresh vegetables.
Harvest for Health cares cancer survivors with master gardeners.
Can you hear this at all?
It's coming through. If you have a vegetable garden in the yard, 3 days before that. What we found is that they not only they also
The study began in 2011 because master gardener and cancer survivor had responsible for planting in the fall, spring, and summer gardens as farmers know. Provided the gardening supplies, raised beds, and responses, the survivors provide the labor. Growing garden survivors fight back against a terrifying disease.
And I think what I found was better about the fact that they have been told a lot more things in my life than I was before, which gave me more confidence that way, which made me feel better about,
Gardener Mary Beth Shaddix believes it gets a lot out from your food.
I love to learn about food, and I always thought maybe it's what I can, I'm trying to do, and how rewarding it is, and I'll take food. But it's that promise food from training yourself, it's awesome different, with fresh from your own side, maybe take it home.
Master Gardener's role is to provide expert advice and assistance and to pick and choose your garden. Backyard spread or garden.
I think there's when typically, weight-wise in my life, and I also think there's when on the kitchen table, no matter what your stage is in life, I think you make it a part of your routine and a part of your natural curiosity about what nature can do. Oh, why not?
With support from the Community Foundation of Greater Birmingham and the National Cancer Institute, Harvest for Health is now recruiting cancer survivors and master gardeners from across Alabama. Homeowners and families.
What I would really like to do is to have a program that was sustainable on the national level.
Prostate is not part of the study any longer, but she has kept the garden going. A simple act of focus.
I think the cancer can be the worst thing that ever happened to you, or it can be
So that's our holistic intervention. Again, what the most exciting thing about this is it's improving physical functioning. So if that can keep people out of the nursing homes after a cancer diagnosis, that's what we're aiming for. That's that. I'm just gonna, I've spent too much time. But where we really do need interventions and where we need people that are young in the audience moving toward, or people that are middle-aged and still have enough energy in the audience moving forward, is to really develop interventions that are sustainable, that patients really can, that are durable. The beautiful thing about this gardening intervention is we interviewed this woman 2 years after her garden was put in, and you saw there, when we came in and we intervened, we gave her one raised bed. Well, you see there that she had 2 raised beds. That was not our doing, that was her doing, and she's still gardening. So, so those are examples of durable interventions. And we have to, instead of, this cartoon shows the mountain coming to Muhammad rather than Muhammad having to go to the mountain. And that's how we have to think about our cancer survivors. They are geographically distributed here. So we can't just expect, oh, I'll open a support group at my local hospital and all these cancer survivors are going to come in. Well, guess what? They won't. So we have to find a way to come to them and to test different interventions. And then the very last thing I want to, very important, American Society of Preventive Oncology is a great group of scientists. Those of you that are into prevention or secondary, tertiary, primary prevention, it will be convening in Birmingham, March the 15th through the 17th. Hope to see you there. So thank you so much for your attention.
We're running late, but we have time maybe for a couple of questions.
Did you just speak at all about protein intake?
I did not.
I'm wondering why you're not spoke about
It was either that or arginine.
Yeah, because the data in humans are not really that good enough to make a recommendation. Yeah, other than really to follow the, you know, the recommendation for that we currently have for humans. That
So you recommend 0.8 grams per kilogram body weight?
Yeah, that is what's in the guidelines currently. However, there is some action to move our guidelines to 1.3 to 1.4. So we just need more compelling evidence that we can really hang our hat on. So that's where you come in. Any other questions?
I was just curious about the vitamin D study. You said that taking it actually increases the mortality rate. How did they measure that?
How did they measure mortality rate?
Yeah.
They followed the
They
people.
were just supplementing them until they passed.
Mm-hmm.